Good evening, everyone. It gives me great pleasure to welcome you all in this webinar today. This webinar is one of a series of free webinars that are held by the Egyptian Representative Committee of the ERC-RCOG in Egypt. The aim always is to support continuous medical education and invite a very rich and engaging discussions together from different parts of the globe. The webinar is held by the ERC. I am lucky enough to work alongside with Professor Yasser Abu Talib, the chair of the ERC-RCOG in Egypt, alongside different colleagues, members, and fellow representatives in Egypt. I'll give the word for Professor Yasser to make the introduction.
So, hi all. This is Yasser Abu Talib, the chair of the Egyptian Representative Committee of the Royal College in Egypt. It's actually a great pleasure to welcome you all on board. Actually, when we started our activity 2 years ago, me, Wafa, Abdelmajid, Ahmed, Muhammad, and all the team, we decided to change our policy. And we discovered that communication and being in just one track, it's a very vital and important. That's why we decided to have a very strong communication with everyone all over the world, mainly from England and from the MENA region as well, and the Arab countries. That's why we tried to involve British people and Arab live in England with membership of the Royal College and fellow of the Royal College as well. We try to engage them in collaboration with members and fellows in Egypt, and as well members and fellow in the Arab region in one activity. That's why we created what's called monthly webinar. Today, I can say that we approached 20 something webinar. And if you want to go through our webinar discussing a subject every time, which is a hot topic with different idea from England, from Egypt, and from the MENA region. So you can go through our webinars on our website. No one can deny that menopause is growing science. And the point is the menopause starting at 51 plus 8 years, and the expected lifespan of women may be 80 years. It means that nearly every woman will spend nearly 30 years of her life in menopause. If we know that the number of menopausal women all over the world is increasing and approaching trillion women all over the world. So it means that we are in a very big, important subject, and we have to discuss it and reach to a way of a proper management and care for women at that age. It's our pleasure actually to have a collaboration with Mina Farm Company to have and to hold this webinar discussing different issue of menopause. May I attract the attention that we will have our international congress, the usual one every year that we used to held in Egypt, the land of first. It will be 24th and 25th of September on the land of Egypt in Triumph Luxury Hotel, and we'll have 2 days congress. It will be a very big surprise to meet loads and lots and lots and many people coming from different countries and pioneers in the field of obstetric, gynecology, urogynecology, fetal medicine, and infertility as well. From America, from England, from Italy, and from Arab region as well. We're going to discuss different topics. And what's nice that we are inviting new guests from India as well. He's pioneer in laparoscopy, and it will be a surprise as well. Next slide, please. Not only that, but we used to hold lots of meetings and congresses beside the congress sessions and training programs. So we will have total laparoscopic hysterectomy course urogynecology course, oncology course, hysteroscopy course, and colposcopy as well. And all of them used to be in one of the biggest hospital, which is belonging to one of the biggest university. It's hands-on. It means that you are going to do everything you yourself, use your hands, and we are going to supervise you. Not from Egypt, but consultant from England with pioneer experience in different fields as well. So we are waiting for you to join us, our international congress, and as well the courses. Thank you very much, and looking forward to see you, all of you with us in Egypt. And now, Wafa, you can start the webinar. Thank you. Have a nice day for everyone. Bye.
Um, Thank you so much, Professor Yasser. I'd like also to extend my appreciation to all respected members of the ERC. We are really working as a one group. Let me share uh, the picture. Okay, let me thank Professor Tariq El-Husseini, Professor Abmegid Sarhan, Professor Ahmed Mahran, who are the fellows representative, Dr. Sameh Salama, Dr. Muhammad Hassan, Dr. Amr Nabil, Dr. Sharif Sulaiman, Dr. Magid Aziz, and the Professor Ahmed Zakaria. All of them, we work side by side. Really, I'm really appreciating all the efforts they put into the ERC. Today's topic, Mastering Menopause Management from Symptoms to Solution. It's a very timely topic as we are seeing many more patients coming asking for complaining of menopause symptoms. And I'm truly delighted today to welcome an exceptional panel of international and the national experts, and then would like to extend my sincere thanks for their acceptance for our invitation. Please allow me to introduce today's guests who are joining, the speakers. We'll start with Professor Haitham Hamouda, consultant gynecologist and subspecialist in reproductive medicine surgery, clinical lead for menopause, serving at King's College Hospital, trustee and past chair of the British Menopause Society. Also, we have Dr. Mariam Nasri, the dear friend of many of us here in Egypt, consultant community sexual and reproductive health, global vice president of the Faculty of Sexual and Reproductive Health. Also, I'd like to welcome Professor Abmegid Sarhan, Professor of Obstetrics and Gynecology at the Kazig University Hospital, and a consultant and a subspecialist in reproductive medicine, and of course, a fellow representative at the ERC. And also, I'd like to welcome Dr. Vikram Sinai, who is Associate Specialist in Reproductive Medicine and Honorary Associate Professor in Women's Health, University College London, and British Menopause Society Certified Menopause Specialist and Trainer for both the it is not the Faculty of Sexual and Reproductive Health now anymore. It is the college. Congratulations for Dr. Mariam, of course. It's the College of Sexual and Reproductive Health, Menopause Care Professional Certificate, and the trainer for the British Medical Society Principles and the Practice of Menopause Care, and the co-founder of Menopause Research and Education and the fund charities. Of course, we would like to thank Mina Pharmaceuticals, who are close to the supporting friend of the ERC all the time for their kind support for this webinar. And of course, we would looking forward to join us in our next activities. Let me now welcome our first speaker, Dr. Haitham Hamouda. He's going to address premature ovarian insufficiency, a very, very important topic. Please, Professor Haitham.
Thank you. Good evening, everyone. Thank you for the introduction and the kind words, and thank you for the organizing committee for asking me to give this talk. So I will just get my screen. So I hope you could see my slide okay. So
Yeah, it's perfect. If you can, please, like slideshow. If you can press on the slideshow.
Yes.
That is the button, the slideshow. Can you see it now?
Not yet.
We can see
No,
the
she means the slideshow from the computer, from your own computer.
I am pressing the slideshow, but for some reason it's not opening it up onto a full
Actually,
screen.
it's clear anyway. No problem.
No. Yes.
Can-
Perfect.
Can
Thank
you can you see it? Okay.
Yes, we can.
So okay. So I will give a summary on premature ovarian insufficiency. What I will do within the course of the talk, I'll give a bit of background on the condition, talk about the implications of premature ovarian insufficiency, and within the course of the talk, I'll refer to the condition as POI, and I'll conclude by giving a summary of the ESHRE, the European Society of Human Reproduction and Embryology recommendations of 2024 on the management of women with POI. So if we go back, the condition was first described by Fuller Albright, who was a Harvard endocrinologist back in 1942. And even back then, he acknowledged within this series that he published the effects of estrogen deficiency on the body on various aspects, bone health and other aspects of health, and the benefits of estrogen replacement. And of course, we've known through large observational studies over time the effects that have been associated with this condition. So what does the term refer to? So the condition happens from a decline in the pool of eggs in the ovaries. As a result, this manifests clinically with infrequent ovulation, which manifests with oligomenorrhea or amenorrhea. And as a result of that, there is hypoestrogenism, a chronic hypoestrogen status, which results in the short-term and the long-term effects of the condition, and a reactive elevation in FSH production to compensate for it in women under the age of 40. If this picture happens between 40 and 45, the term that is used to describe it is early menopause. But in reality, whether it's POI or early menopause, under 40, 40 to 45, it's a continuum, and both groups you would treat in a similar way. And these two groups, you would look at estrogen replacement as a prevention, unlike your discussion with someone who goes into the menopause at 50 or beyond, where you're really considering HRT for symptom management. But in this context, for these two groups, you are talking about symptom management, one aspect, but more importantly and equally importantly is the general health effects, bone, cardiovascular, and cognitive, which I will address in the course of the talk. How prevalent is the condition? Historic reports, which you would have read in many papers, often quote to 1%, but you're getting more recent reports that refer to 3.7 up to 3.7%. So a higher prevalence than was thought previously. And with early menopause, 40 to 45, anything between 5 to 8% of women are thought to experience this. The younger the individual, the less the probability. So under 30 is estimated to be about 1 per 1,000 of women. And of course, we've got guidance that I've put up here, and I will send the slides for you to look at later on. Of course, the NICE guidelines of 2015 that were subsequently updated in 2024 address premature ovarian insufficiency. You've got the ESHRE guidance, which I would recommend you look at. It's a very detailed document that was updated recently, again, published in 2024. And the British Menopause Society consensus statement that's available on the British Menopause Society website, again, that addresses various aspects of the condition. So what are the issues that you would expect to see? Well, symptoms, menopausal symptoms is a short-term effect, but the long-term health effects are, again, it's very important to address these: cardiovascular, bone, cognition, and fertility. Many patients we see, fertility is a major issue for them. And really, once fertility is an issue, many patients don't even want to listen about the other aspects, because all they're thinking is what's going to give me the best chance to get pregnant. So it's really important to try and look at it in a kind of holistic way. So what are the symptoms? So this is an interesting summary of the literature that was published in the ESHRE guidance. And contrary to what we have often said, what the studies have shown and what guidelines have said, that vasomotor symptoms are the commonest symptom, this interpretation of the literature, as you could see, showed that psychological symptoms, mood and brain fog had a higher prevalence. So they were reported in about 7 out of 10 women. Vasomotor symptoms were still very common, about 5 out of 10. And of course, a whole range of other symptoms: sleep, fatigue, sexual problems, dry eyes, joint aches, headaches. So a varied range of symptoms as well. But it's relevant to highlight the box that you can see at the bottom, that is up to 15% or so of women do not have symptoms. And it's really important, if you have a younger patient under the age of 45, whether they have symptoms or not, that you consider hormonal replacement for bone, cardiovascular, and cognitive protection. So what are these long-term effects? So I'll deal with these and over the coming few slides. So I'll start with cardiovascular disease. So we have large observational data that show that women with POI have an increased risk of cardiovascular disease, cardiovascular morbidity, and cardiovascular mortality. And this meta-analysis had included more than 190,000 women with more than 9,000 cardiovascular events, showed a significant increase in ischemic heart disease and total cardiovascular disease. So what is the conclusion of the literature review? So the British Menopause Society recommendations concluded that hormone replacement is likely to lower the long-term risk of cardiovascular disease associated with POI, and any form of hormonal replacement, whether it's HRT or combined hormonal contraception containing ethinyl estradiol, would both be suitable, but there may be marginal advantages with HRT over the pill from a cardiovascular markers and blood pressure point of view. But I would stress the point, any form of hormonal replacement would be significantly better than not taking anything. And what did the ERC-RCOG guidance conclude from their literature review? Very much along the same lines, and that women should be counseled about the increased risk of coronary heart disease, heart failure, and stroke, and increased risk of cardiovascular mortality, as well as all-cause mortality, if hormone replacement is not given. So the recommendation is to consider hormone replacement at least until the natural age of the menopause. If we move on to bone health, again, we've had data over many years. You can see this paper goes back to 1965, demonstrated very eloquently that bone density and bone markers are maintained in the reproductive years, and you could see that decline beyond the menopause. How significant do we think that is? Well, you've got, again, large observational data that suggests that women with POI have a higher risk of lower bone density. Is estimated about to be 2 to 3% lower than controls in the spine and in the hip. The prevalence of osteoporosis and POI is estimated to be about 8 to 14%, and there's a higher prevalence of fractures reported. So how do we translate that into clinical practice? Again, I've just put here the summary of the literature review from the British Menopause Society guidelines and from ERC-RCOG, that hormone replacement should be considered the treatment of choice for the prevention and treatment of osteoporosis in women with POI, and this should be continued at least until the natural age of the menopause of 51. And you would really want to avoid non-hormonal anti-resorptive agents. So certainly you would want to avoid bisphosphonates in the younger age group. We don't know what their reproductive effect is. You often can use them for a limited period of time. So there will be, in this group in particular, you want to limit them and have them for a later stage in life and use HRT in those years. Again, it's concluded that HRT and combined hormonal contraception are both suitable options, but HRT may have marginal advantages in improving bone health. And the ERC-RCOG guidance also recommended that hormone replacement should be considered to prevent osteoporosis and to continue at least until the natural age of the menopause. Moving on to the next area, cognition. Again, we've got large observational data, and really the seminal work by Walter Rocca and his group at the Mayo Clinic, the oophorectomy and aging study. It's a very important study and really very much guided this area. What they found within this report, that oophorectomy, whether unilateral or bilateral, was associated with a significant increase in the risk of cognitive impairment and dementia, and that hormone replacement negated that. So women who took hormone replacement until the age of 50 didn't appear to have an increased risk. So this is a third aspect to consider, as well as bone and cardiovascular. And also, Walter Rocca and his group, what they did, they did a literature review, and they coined the phrase the cognitive window of opportunity and timing hypothesis, and again concluded that with early menopause, consider hormone replacement until the natural age of the menopause of 50. Now, moving on to the benefits and the adverse effects, the next question is, what does POI do to the risk of breast cancer, and what does HRT intake in POI due to the risk of breast cancer? Because that's often something women and healthcare professionals worry about. So really, first thing I would say is that the risk that we quote to women 50 and over does not apply to this group, albeit even in that group, it's a small increase of risk, but it's different to the younger group. So you've got really two questions. What is the risk of breast cancer in women with POI? And what is the risk of breast cancer in women with POI taking HRT? So for the first question, you've got the Shanghai Women's Health Study addressed that, and they found that women with POI in early menopause had a significantly lower risk of breast cancer compared to controls. And the second question, what does HRT do to that risk? The Danish Cancer Registry study addressed that, and they found that the risk does not increase above that in controls. In other words, if you go into the menopause at 42 and you take HRT, the risk of breast cancer in that individual is unlikely to be higher than her risk had she not gone into an early menopause and not needed HRT. And ESHRE 24 also concluded a similar conclusion in that women with POI should be informed that the evidence does not suggest that HRT increases the risk of breast cancer compared to women of the same age without POI. So that's, I think, it's an important part in counseling, because that's often an area of concern. Now, in the coming few slides, I just want to talk a little bit about treatment options. So what are the treatment options? So HRT versus the pill, which one is better? What's the difference between them? So the pill, most pills contain ethinyl estradiol. So if you want to look at equivalence, it's thought that 10 micrograms of ethinyl estradiol is equivalent probably to about 1 to 2 milligrams of estradiol. So you're getting a higher dose of synthetic estrogen. That's how the pill works. It suppresses ovulation by giving supraphysiological doses of estrogen. Also, ethinyl estradiol has a longer half-life. So there are small differences in how they work. Of course, on the other hand, generally, you're giving it 21 days with a 7-day break. So these are all the differences to consider. And most pills on the market, certainly in the UK, are 20 to 35 micrograms. But also we have 2 pills that contain estradiol. So Clara and Zueli are 2 conceptive pills that have estradiol, so they've got a more natural estrogen. So if you have someone who wants to be on the pill, maybe because they don't want to tell their friends they're on HRT, maybe they want contraception, then I would say these would be preferable to synthetic estrogen pills. What's the difference between them? So if you look at a pill with synthetic estrogen and you look at HRT, which one is better? What do we know? Well, the answer is we know very little. There are only 2 studies that have been done, very small sample size. And of course, now there is a study happening across the UK called POISE, looking at that in a bigger sample. But what we know from these studies that have been done so far, this is Hilary Critchley and her group in Edinburgh, that if you took estrogen, transdermal estradiol through the skin with micronized progesterone, and the other group had ethinyl estradiol with normotestosterone, so an entirely synthetic combination, HRT had a significantly better effect on systolic and diastolic blood pressure, renal function compared to the pill. And also, they looked at bone density, and they found there was significant improvement in bone density with HRT compared to the pill, but the sample size was small. So that bit you have to take within context. And again, I would stress the point, either of these is better than not taking anything. The other study, this was Beth Cartwright, who did her work with Janice Reimer at Guy's and St. Thomas Hospital. And within this study, again, an important study, but again, a small sample size. They lost lots of patients to follow up, and not many patients didn't continue. But they compared the pill to HRT. And this one, what they did, HRT had estradiol, the natural estrogen, with levonorgestrel, and the pill had ethinyl estradiol would never know gestrol. In other words, both groups took the same synthetic progesterone, but one with natural estrogen, one with synthetic estrogen. And they also compared the group that didn't want to take part in the study and took no treatment. And they found that any form of hormonal intake, be it HRT or the pill, was better than no treatment, but HRT had marginal advantages in improving bone density. So in the next couple of slides, I would want to talk about fertility. So again, fertility, it's important to counsel women to say that if you have POI, you can still get pregnant, but your chances are lower. We see many women who've been told there's no chance you can get pregnant, and that's not correct. But of course, the chances of getting pregnant are going to depend on the age. The younger the individual, the more the chances, and on the frequency of ovulation. The more frequent their ovulation, the more likely. The less frequent, the less likely. If someone says to you, I haven't had a period for 3 years, 2 years, clearly their chances are going to be significantly lower than someone who has a period every 2 to 3 months. Estimated to be about 5 to 10%. The risk of miscarriage is no different. So the risk of miscarriage is similar to age match controls. And again, the pregnancy chances once they get pregnant, or the chance of getting pregnant with their eggs, is similar to age match controls. What else do you need to mention? Again, many women worry about taking HRT. It's important to say that HRT is not contraceptive. And again, the counter side of that, if they don't want to get pregnant, they should use contraception. Egg donation remains the realistic option for many. So when we see someone, if they're still having cycles, we will say to them, try naturally. That's your best chance of getting pregnant. IVF with their own eggs is unlikely to be successful. Egg freezing with their own eggs is unlikely to be successful once they've had established POI. So if you look at it, if you're seeing a patient and they ask you about that, as I said, IVF and egg freezing are unlikely to be helpful. But if someone is at risk, that's where egg freezing would be an option. So if someone is about to have chemotherapy, radiotherapy, or someone may have a strong family history of POI, or they've got severe endometriosis, they're having repeat surgery, ovarian cyst, and so on, then egg freezing would be an option. Ovarian tissue freezing carries promise, but in practice has very limited role. So at the moment, if someone is at risk, not already established POI, at risk of POI, they, let's say, about to have chemotherapy, radiotherapy, or any of the other groups I've mentioned, they can have ovarian tissue frozen and then put back at a later date. At present, the only application is to re-implant that tissue into the ovary and hope it will get blood supply, activate, ovulate, and they get pregnant. And so far, over 200 live births have been reported with this technique. Of course, where this will take it to the next level would be when science progresses enough that the eggs can be matured in the laboratory, so in vitro maturation of the oocytes, because then you may have a small part of ovary that has got thousands of eggs, and that could give you a huge number of chances. But of course, that's not an application at this moment in time. And very briefly, the future directions, as I've just referred to, in vitro activation, but stem cell is another area, and platelet-rich plasma treatment. But these are all, so far, have got a very limited role. And it's really important to say that these should be done in research context at this moment in time. How about prediction of the age of the menopause? We are seeing more and more patients who will say, right, I want to know where I am, and I want to know, am I at an increased risk or not? Should I go and get my AMH checked? What should I do? So AMH, any of you who work in the field of fertility will know it's a very useful test as a reflection of ovarian reserve. And of course, now it's become very much part of the bread and butter of IVF and fertility assessment, and giving us a reflection. Of course, it's not perfect, it's far from perfect, but it's very informative in that context. But if you want to ask the question and say, right, if you do your AMH now and it's 10, what does that tell you about the risk of when that individual can go into the menopause? And of course, you've probably seen there are the Dutch groups and the Persian groups try to do all these prediction things where you put the age and you put the AMH and you predict when the age of the menopause. The numbers are small. So really, at this moment in time, we haven't got a meaningful way of telling us when an individual can go into the menopause. However, what is predictive if the AMH is very low? because if the AMH is very low, that individual is likely to go into the menopause soon. But if it's normal, the prediction becomes less. But of course, it's an area with ongoing research. But as it stands, it will give you a reflection of where things are now, but not necessarily of how things will progress. Now, in the final few slides, I'm just going to present a summary of the ESHRE guidelines that were published in 2024. So what ESHRE put as a diagnostic criteria is oligomenorrhea of at least 4 months, and one FSH, they considered one is fine. So historically, you do one and you do a repeat. They found that the literature review that if you do one and it's above 25, that's conclusive enough. You don't need to do it in the early follicular phase. You could do it any time of the cycle. Clearly, if it comes back low, as you know, FSH has intercycle variability, then repeat it again. If it's still low, you might even need to do an AMH to complement the picture. But if you get one elevated FSH above 25, that's enough to make the diagnosis. AMH, whilst they recommended not to use as a primary diagnostic test, can be considered if the results are inconclusive. You see patients who've got symptoms and an FSH of 9, symptoms and FSH of 10, and of course FSH, as you know, goes up and down. So that situation, you could say AMH or even a follicle count may be helpful to complement that picture, but of course not as part of the routine screening test. They emphasize the point of shared decision-making and support. And of course, any one of you who sees patients of POI, you're seeing a young individual, maybe been on the pill, come off the pill, no periods, and all of a sudden you're saying to them, you might not have children, bone health, cardiovascular mortality, risk of dementia. You're overloading them, you're flooding them with a huge amount of information. And often they're going to come to the clinic. Clinics are busy. They're going to be seen. They're going to be 4 or 5 doctors sat in the rooms. It's really important that support is available. And of course, that's difficult everywhere in the world because of the strains on the health services. But it's really important to try and support women as much as possible. But also for patients who have got POI, to think about relatives. So you might see someone with POI, ask them about, do they have sisters? How old are their sisters? And maybe their sisters need to have a discussion about where they are because there is a higher prevalence in families. And ESHRE concluded, as I alluded to in the earlier slides, that there is a reduced life expectancy with untreated POI, increased risk of cardiovascular disease, increased risk of cardiovascular mortality, increased risk of osteoporosis and fractures, and increased adverse cognitive effect as well as musculoskeletal effect. And they recommended, based on all of this, that HRT should be, and hormone replacement should be considered until the average age of the menopause of 51. What doses to be used, of course, that's a bit more contentious. We haven't got really good evidence to guide that question, but the concept is a slightly higher dose than average. When you're treating someone who's 50 and above, what you're doing, you're trying to give the lowest effective dose to control the symptoms. With POI, you are really aiming for a physiological replacement. But of course, there are variations in absorption. So not everyone's going to get what you're giving them, but they recommended about 2 milligrams or more of oral estradiol, 100 micrograms of if you're giving a patch, as an equivalent as your kind of level that you're looking to start with. And also to mention that HRT is not contraceptive, but also a relevant point is to say, if you're giving higher doses of estrogen, the dose of progesterone needs to match it. So it's really important that you consider that, and also to give sequential HRT if someone's trying to get pregnant, because that will maintain the health and the cyclical activity of the endometrium. Testosterone may be considered for treating low sexual desire, but really the other benefits of testosterone, as you would say to people who are 50 and above, have not been tested. So thank you. I will stop here, and of course at the end would be very happy to take questions if you have any questions for me. Thank you.
Oh, thank you so much, Dr. Haytham, for the very comprehensive presentation. Actually, it's very important, and especially those of the clear definition and the treatment options for the ESHRE 2024 are very, very clear, made things clear in our minds. And I believe if we stick to this diagnosis, we may have missed many patients through the years. I have raised the hand from Professor Abdelmegid. Would you like to have a question here?
Thank you, Dr. Haytham, for this interesting talk. I'm actually interested in this topic, and the percentage given for spontaneous pregnancy after the confirmed diagnosis of premature ovarian insufficiency in the box is 5 to 10. But myself, I think this percentage is much higher than I see in regular practice. I merely remember 2 cases throughout my career who got spontaneous pregnancy after confirmed diagnosis of premature ovarian insufficiency. What do you think, sir?
I mean, I agree. I mean, if you look at the evidence, this comes, thank you for that question. This comes from younger patients. I mean, if you look at the series, and of course, there are case reports and small series, but average age 31 to 33. But a big part of it is how frequent are their cycles. So if you're seeing someone in their early 30s who are still having cycles at relative frequency every 2 months, 3 months, so on, they're far more likely to get pregnant because they're ovulating. I mean, again, you've probably seen data that patients with low AMH who have got regular cycles have got similar chances of getting pregnant, similar to people age match controls with normal AMH, which goes with the same logic. So it does vary and it's age related, but a big part of it is the frequency of ovulation. And of course, there have been reports, larger series, better control studies suggest it's about 5% or less than 5%. So I agree. I mean, the 10% is probably a generous figure, but of course, that's what that review suggested, and that's been quoted really widely, but there were a younger age group.
We have I'm sorry, thank you. We have another, do you have anything more, Dr. Amir? Okay, we have another question from...
No, thank you, it's clear.
Okay, thank you. We have another question from Dr. Fatma Murtada. She's asking if there is any role for the dihydroepiandrosterone medicine in improving the AMH in those patients. If there is any other medicines that can decrease the FSH or improve the AMH.
Yes, thank you. So again, I mean, if you go back to the physiology, the embryology of it, eggs are not generated after birth. And that kind of, in a way, explains why all these things don't work. Because the issue is a decline in the pool of oocytes. And again, you probably see it in the fertility setup as well. DHEA has very little benefit. I mean, you've seen the studies on it, you've seen the reviews, albeit with the limitations of the power and the sample size of these studies. They're not effective. And in a way, it's not surprising because you're expecting something to kind of generate new eggs, which they can't. And again, these minor changes in androgen, etc., in the ovarian environment have got very little benefit. So really, very little role. And I wouldn't really encourage people to take it because, of course, on one hand, whatever's been published doesn't show a benefit. And also, we haven't got enough good safety data. And most DHEA preparations are compounded, bought over the internet, which are issues with purity and safety. So all around between, does it work? Probably not. And we haven't seen anything to support it. And you've got the limitations with this. I would say avoid these. And really, it's going to be a question of saying if someone's got regular cycles, keep trying naturally, try regularly. And of course, when you hit the point where that's not working, then it's a question of egg donation, adoption, or some people end up facing the situation of being childless. It is difficult, but certainly I would say these interventions, one would take them with their limitations. And don't forget supplements, etc. It's a big commercial exercise, and people end up buying various things, taking them in the hope it'll do something, but really with very little evidence to say that they have got any advantage.
Thank you. I have plenty of questions here, but I'll take only 2 and then complete at the end if we have some discussion at the end of the webinar. One asking about can HRT taken while on chemotherapy pills? If there is any interaction or any contraindication for taking HRT while taking the chemotherapy?
So there's theoretically, you would say there is no reason that would be an issue. If you think about it, what is HRT? HRT is estrogen and progesterone, similar to what the ovaries produce. So anything that you would be happy for the woman to have her own natural cycles with, you could give her HRT. Of course, what you might want to do is think about thrombotic risk. Clearly, if someone's having chemo, they're unwell, maybe their risk of VTE is going to be slightly increased, risk of inflammation slightly increased. So certainly in that group, we would give transdermal estradiol and micronized progesterone. So a very neutral effect on liver pro-inflammation markers, on coagulation cascade. But beyond that, medically, there is no reason. It's similar to someone, if they've got their periods and you think, well, they've got their periods, they're fine, they've got their own cycles. This is a similar logic, but give it in a kind of more neutral way, transdermal estradiol and micronized progesterone.
Thank you. Another question about any specific management for the POI in teenagers from Dr. Megid Mikhail.
Yeah, thank you. That's really an important question. Of course, in this group, you are talking about also initiating puberty in secondary sexual characteristics. So that becomes another dimension that comes into the equation. So you're not just talking about bone, cardiovascular, cognitive. You're really talking about developing secondary sexual characteristics. So it's really important once you've reached that diagnosis. Of course, you need to think about gonadal dysgenesis as well. So it's even more emphasis to say, do a genetic assessment to see where they are. But let's say you've done it, either genetic screening is normal or maybe Turner or other aspects, which again, you might need to investigate certain aspects, cardiovascular, correction of the aorta, etc. But it's giving estrogen. And if you're giving it in that group, you're going to start with a low dose and slowly build it up. And often you will say a year down the line, you will start adding progesterone. And really what you're doing here, like I said, in addition to the general health benefits, you're also helping that kind of puberty development from sexual characteristics.
Thank you so much, Dr. Hamouda. We appreciate your presence in the webinar. I know it's a long day at work, but we appreciate if you can just stay with us till the end or join us at the end for more questions, because I have questions for you. Thank you. Now it's my great pleasure to introduce our next speaker, Dr. Mariam Nasri. Many of you know Dr. Mariam personally. She is going to address contraception during menopause transition. Please.
Thank you, Dr. Wafa. So I'm going to try and share my screen. Can you see my screen? And I'll put it on slideshow in a minute. Slideshow. Yes. So, can you see it now? Yes?
Can you get it in the show format?
But not in slideshow.
No, it's not coming in slideshow. It should. Let me just close it, stop sharing it, and then do it again. Share.
Can you just press on the slideshow up there? Oh, okay.
Yeah, yes, I will do that right now.
Yes. Okay.
The Zoom bar is in.
Yes. Perfect. We can see it clearly now.
Doctor, you are muted.
Dr. Mariam, you are muted, and we can see your presentation clearly now.
I'm not muted anymore.
Yes.
And can you see it?
Yes.
Yeah, it's okay.
Excellent. Okay, I have to be very careful which keys I'm pressing on the laptop. So thank you very much, Dr. Wafa and Professor Yasser, for inviting me. It is a great pleasure to be amongst colleagues and friends, obviously. So I'm hoping to, through this 20 minutes, talk us through contraception during the menopause transition. So I am a sexual and reproductive healthcare consultant, and you can see that I've put the new logo of my college up. So as Dr. Wafa mentioned, our faculty is now a college, and we graduate from that college. But I'm also an accredited BMS specialist, FSRA specialist, and trainer, and all of that. So in the next 20 minutes, we want to talk about what we can do for women during the menopause transition sorry, it's taking a while. Okay. So we want to, I've put my take-home messages at the very beginning so that you can focus on what you're going to learn from this talk. Hopefully, I can talk you through which contraceptive measures, which contraceptives are better used during menopause, and can contraception be used alongside HRT? Is HRT itself contraceptive? Haytham has already answered that. And which contraceptive methods we can use along HRT, and when can we stop contraception? So we are talking about perimenopause here rather than menopause. So when women stop their periods after a year, we obviously can stop their contraception because we assume that ovarian activity has completely stopped. However, at least in Europe, we are more and more prescribing HRT for perimenopausal women. And perimenopausal women can be anywhere between 45 and 55, and they are still having periods, and then they want to go on HRT, and we need to ensure that they know that they are still fertile. Because from some data, we know that about 20% of women who are between 40 and 44, if they have regular intercourse, unprotected intercourse, and about 12% of those 45 to 49 can get pregnant after a year. And the unfortunate thing is that in women over 40, more than a quarter of them end in termination. So it does show that it was an unintended pregnancy. We also know, and we've got lots of evidence of this, that obviously pregnancy and childbirth after 40, after the age of 40, confers a greater risk of adverse events for the fetus and the mother both. So that is why we think special attention has to be paid to women who are going through menopause for their contraception. We know that in addition to all of what I said about the background and the data, we know that there is an increased background risk of cardiovascular disease, deep venous thrombosis, obesity, and breast and most gynae cancers. And the problem is that these can affect our choice of contraception because contraception has got side effects and effects. Contraception doesn't actually affect the onset or duration of menopausal symptoms, but it can mask the signs and symptoms of menopause, and we will come to that. And we know that there is a lot of misinformation surrounding fertility for older women. We get a lot of these women in our sexual health clinics coming after 40 or 45 telling us, I know I'm not going to get pregnant anymore, I'm too old. And then we get them going onto HRT and again thinking, I'm menopausal, that's why I'm on HRT, so I won't get pregnant, whereas they're actually perimenopausal and they have gone on HRT. So my talk is basically around the guidelines of the Faculty of Sexual and Reproductive Healthcare, which basically, based on all the things that I just said, decided that there is actually a separate guidance needed for contraception for women who are aged over 40 years. And they've collected all the evidence, made it much easier for us to go through these guidance. It is a guidance, so it doesn't mean that everything is included, and clinicians may make decisions that are not in this guidance. But the guidance has collected the evidence that is available or was available up to the time that it was produced. And in case of no evidence, they have agreed and have added consensus statements. This guidance, you've just listened to Haytham's talk, doesn't apply to POIs because that's a different category of women. So this is one of the tables in the guidance which shows you women by age group using contraception. And if you look at the top, it is alarming that women don't use contraception as they grow older. And we know that about 72% of women older than 45, they don't attend their family planning clinics, they don't go to their GPs, they don't seek contraception. The reassuring numbers are the numbers lower down, which show that they do go for female sterilization or vasectomy as they grow older, which is a sign that they've completed their families as well. I hope you are familiar with the UK medical eligibility criteria, which is the adaptation of the WHO medical eligibility criteria. Again, lots and lots of evidence has gone behind this. And if we look at all of the methods that we have there, all of them can be started after menarche. So we can use them. We are going to talk about when we're going to stop them. So let's talk about different methods of contraception. So the good old IUD, the good old intrauterine device that has been around for centuries, but now in its T-shaped form has been around for decades. It's inexpensive and it's very protective. It can be used as PC-IUD, which I mean postcoital IUD, which means it can be used after having sex as an emergency contraception. The very good thing about it is that it doesn't interact with HRT. So we can fit it even if the woman is having HRT or any medication. And what we do in the UK is most of our IUDs on the market have more than 300 square millimeters of copper on their stem or combined on their arms. And what we do is we know that fertility declines with age. So all of our methods become more effective with age. So we insert these IUDs after 40, and despite the license being 5 or 10 years, we know we've got robust evidence that they can be kept until menopause, post-menopause. However, in women over 40, with all the advantages that we've said, it may not be appropriate if they've got heavy menstrual bleeding or they have pain with their bleeding. So what do we do when we want to fit IUDs? This is similar to all women of any age that we want to fit IUDs. We assess their eligibility, we discuss it with them, the pros and cons, and we take a sexual history. And it's really important not to forget that these women are also at risk of STIs, and STIs have increased in women of older age. It is not just the young people who are at risk of STIs. And if there is a risk, or if they request, we will do an STI screen. Most women wanting an IUD do not need any further investigation, but you come to the age of 40 and above, and this is when women might be suffering from heavy menstrual bleeding. You might have concerns about any gynae pathology, and you might want to do a full blood count and a pelvic ultrasound, plus minus an endometrial biopsy, if they have these symptoms. So the same thing we do for our levonorgestrel intrauterine devices. And here, I'm talking about the 52 milligram. And in the UK, we now have 3 brands of 52 milligram intrauterine IUDs. We know that obviously they can be used for heavy menstrual bleeding, and the quality of life of women who have had levonorgestrel IUDs, being it Mirena, Levocert, Benilexa, whatever it's called in any other country, the quality of life has improved as much as hysterectomy, and this is really important for us. So it can reduce pain with menstruation, endometriosis, adenomyosis. It's not associated with increased risk of VTE, MI, and stroke up to now. And although the evidence for us is interpreted in the license and it says 4 years for HRT, both the British Medical Menopause Society and the Faculty of Sexual and Reproductive Healthcare have agreed that based on all of the other evidence, it can still protect the endometrium against our estrogen administration for up to 5 years for HRT. So this is the additional benefit. You are giving a woman a levonorgestrel IUD, a 52 milligram one. You're preventing her heavy menstrual bleeding. You're providing her contraception, by the way, to 8 years. And you're giving her the progesterogenic arm of her HRT. So you just need to add estrogen to it. In these women, there's probably a higher chance that they will have ablation for all sorts of reasons. And there is a small study that shows insertion at the time of ablation was safe. And a few women had to remove it with side effects, but it didn't carry on to say what the removal was and how the removal was. And we don't have studies to tell us that an interval insert, what about an interval insertion, that is an insertion after a few weeks after ablation. And our concerns are about the adhesions and the risk of perforation and the risk of need and the need for repeated hysteroscopies. However, we still do that. We counsel women and we discuss it case by case, and we do offer, and mostly it's offered during the ablation, but even after that it is offered as well. But we do have other levonorgestrel IUDs, and they have a lower dose of levonorgestrel in them, so 19.5 and 13.5. And they are very good contraceptive methods. The 19.5 is has got evidence for 5 years, and the 13.5 for 3 years. Very good methods, easy to insert. Again, you would think that they should be able to oppose the estrogen, but because we still don't have data, and trials are happening, but because we still don't have data, we don't use these off license unless they're monitored and they're in trials and in specialist centers. So if a woman comes to us and has Kyleena and JDES for their contraception, then we will most possibly add a progesterone on top of it if we are going to give them HRT, estrogen for HRT. Etonogestrel implant, we use it a lot because of the lowest failure rate of all contraceptives. It can be used for 3 years. It can be used up to the age of 55, and again, isn't associated with the risks that we are worried about. It can alleviate menstrual and ovulation pain, but unfortunately, the bleeding patterns are unpredictable, and sometimes we have to add more hormones to stop that bleeding pattern. And again, with the implant, we don't have evidence to suggest that we can actually use it on top of contraception for HRT. But we can use it alongside HRT. So if they are having sequential HRT and they want to use an implant, they can use an implant for contraception. We've got depomedroxyprogesterone acetate. We have two types of it. We've got the intramuscular one and the lower dose subcutaneous one, which acts exactly the same. There are some minor differences between the two, but the evidence relates to both of them. And because it alleviates menstrual pain and endometriosis, the National Institute for Clinical Excellence has actually suggested that it is a potential treatment for heavy menstrual bleeding. And a lot of women experience amenorrhea on Depo. And we've also got observational studies that it might have a potentially protective effect on the risk of endometrial or ovarian cancer. Depo, we can use alongside HRT, sequential HRT. Obviously, we're concerned about initial bone loss, but studies have shown that the initial bone loss isn't repeated or worsened by menopause. However, we are very cautious with any risk factor that they have. We take that into consideration when we are offering them the Depo. We don't necessarily offer routine bone density scan only for the reason that they are on Depo. We have calculators that calculate all the risks, but we review them every 2 years. And after 45, we consider other options as well, because category 1 of UK MEC, if you refer to categories at the UK MEC is for safety of contraception. So what it says to you is category 1, go ahead, no problem. Category 2 says the benefit outweighs the risk. So you can still go ahead with it if you think it's going to be beneficial for the patient. But at 50 years of age, we will change the Depo to an alternative method. So, as I said, in theory, we would think implant and Depo, why are they not used as the endometrial protection progestogen arm of HRT? We don't have any data. So at the moment, they are not used as that. So if they are used with HRT, they are used as a contraception, and progestogen has to be there to protect the endometrium. How about the progestogen-only pills? Well, on the market, these are the ones that we currently have on the market. We've got the older generation, the traditional pills that we call them traditional pills, norethisterone or levonorgestrel, and then we've got drospirenone and desogestrel, who are our newer kids on the block. And they mainly work by stopping ovulation. So they are different to our traditional pills. And as fertility declines, the traditional pills become increasingly effective because although they don't stop ovulation as much as the others do, but they have the other effects that will help their efficacy. But we do know that desogestrel and drospirenol pill offer some benefits in the management of pain with menstruation and endometriosis. And we do increasingly use them for these off-license uses. There isn't currently much evidence of an association with any of the VTE and stroke and MI, and we don't think our available evidence doesn't show there's an association between bone mineral density loss. But we do know that there is evidence of a small increased risk in breast cancer, although the absolute risk remains very small. And let's remember these women are under 50. POP can be used alongside sequential HRT, so it isn't surprising for us to have a woman on sequential HRT who is still taking her mini pill, and it can be used up to the age of 55. And luckily, it's got relatively few contraindications. Now let's go to combined hormonal contraception, and Haytham did touch on its use as HRT. So let's talk about it as a contraceptive method. So basically, it's the reason it's favorable. It's a good contraceptive method. Yes, it does have side effects, but again, it can control bleeding, and there are studies that it can alleviate vasomotor symptoms as well. It can reduce menstrual pain. It's associated with reduced risk of ovarian and endometrial cancer. The positive effect on bone mineral density is not as much as HRT. But if women under 50 want to use a friendly HRT because they don't want to be on HRT, they just want a pill in their pocket, then combined hormonal contraception can replace HRT, and we'll talk about it a little bit more, under the age of 50, provided they have none of the contraindications that we talked about. We have to be very careful in these women because they have more contraindications to, say, combined hormonal contraception. So if they're above 35 and they smoke, we can't start it on them. Migraine with aura is another contraindication. We know that VTE risk sharply increases in women in this age, and we know that there's an increased risk of breast cancer and a small increased risk of MI and stroke in these women. So how do we assess these women for CHC? As I said, we do have the wonderful UK MEC that tells us the contraindications. We have different options, pill and patch and ring. They have slightly different side effects and uses at times, but generally the evidence relates to all of them and the device relates to all of them. And I don't know whether you use the continuous regimen of pill taking or not, but we are increasingly using that because it increases adherence and reduces a lot of the side effects and helps PMS and menstrual pain. And the way we do it is, there's different ways of doing it, but some traditional, we call the one that we ask the woman to take 21 pills and then stop for 7 days, have a bleed, and then try again. But the new way of taking the pill is actually no bleed needed, carry on with the pill. If it's a 21-day pill, just carry on with it. And then we've got different other different pills as well that we can omit the placebo. And then we let them carry on with it. Now, they can carry on with it until they bleed. At some point, they might bleed. This is one way of using it. And if they bleed for more than 2 days, then they stop, have a small break, and they then go back on it. When we are giving it to them, we make sure that we are taking the risk factors for cardiovascular disease in mind, and we check their blood pressure and BMI, and we continue to do that annually. Now, for contraceptive purposes, the guidelines advise that we want to use lowest dose of estrogen, which is our ethinyl estradiol, and the lowest dose we have in the market is 20 micrograms. And we want to use the older generation of progestogens, which is levonorgestrel and norethistran, because of their lower risk of VTE. However, Haytham also referred to that. We have newer pills in the market, and they have got the newer generation estrogens, and we've got the ones with estradiol and the one with estetrol. And what we're hoping with, although we still don't have the data, but we're hoping that hypothetically these are more similar to HRT and should have less side effects than ethinyl estradiol, which is a very synthetic hormone. So in these women, you do have other methods. Obviously, you can still sterilization, as you saw from the data. They do appear to have finished their completed their families. They might want to go for sterilization. Fertility awareness methods rely on the cervical secretions and on their temperature and on their menses. And because during this period, the menses might not be very regular, it might not be the best idea to use fertility awareness methods. Caps and diaphragms can still be used as barrier methods that are under their control. But again, they might have prolapse, it might not fit very well, or they might have arthritis, it might not be easy. Condoms are still a good option because they can prevent STIs as well. And withdrawal remains an option. However, it's better for spacing pregnancies because of the high failure rate that it has. What about emergency contraception? Emergency contraception, we have 3 methods, and in everyone, we would rather give them a copper IUD because of its near to 100% efficacy if the woman has been assessed appropriately. However, sometimes we need to estimate ovulation time for copper IUD insertion, and irregular menstrual patterns make it difficult. Levonorgestrel pills can be used, but we have to be careful with ulipristal acetate because of the fact that you cannot give it to someone who's had hormones in the last 5 days or wants to use hormones in the next 7 days. So actually, if it's given with HRT, it might not work. So this table just summarizes what I've already said, that as you can see, safety with HRT, all of the methods are safe to use. Other than the combined hormonal contraception that isn't used with HRT, because under age of 50, it can actually be used instead of HRT. But at the age of 50, we do recommend that everyone is moved to a progestogen-only method and rather not the depot. And when do we not need contraception? We did say that menopause as a natural phenomena, if they've had 1 year of no cycles over the age of 50, well, they're menopausal. But to be very careful, if they're under 50, we need to wait for another 2 years to stop their contraception. At 55, we believe that at least in the UK population, if there are any cycles, they are anovulatory. But if women insist that they want to continue with their method, then that is acceptable. But as I said, combined hormonal methods and depot have to be changed at 50. And how about FSH measurements? I think that becomes really difficult when a woman is amenorrheic on our progestogen-only methods. And that's the only thing I want to clarify here, not the whole idea of FSH measurements, which is discussed in the NICE and is different. It's the fact that if a woman is on progestogen-only methods, because the amenorrhea might be related to her levonorgestrel IUD intrauterine system or her implant or her progestogen only pill, what do we do if she really wants to know that she's menopausal and she can stop her contraception? So what we tell them is that whilst they're on HRT and estrogen containing contraception, we can't test it, and they'll have to stop it and wait for 6 weeks so that we can get all the system back and we can measure the FSH. But if they're on POP or implant, we can still test FSH. And if the next step, and if we want to test it when they're on depot, we'll just wait for the next dose to be due and we will test it then. And obviously, it's easy to understand that with the intrauterine coils, intrauterine devices, we don't need to wait. And this is just summarizing the recommendations about stopping contraception and when to do an FSH if they're on that method, not without that method. Just one last slide, and that's about post-menopause. So the woman who has stopped bleeding for a year and wants to start combined continuous HRT might start to bleed. But this doesn't mean that their fertility is restored. And we get this myth a lot with women. That's why it's been addressed in the guideline as well. And we don't know if this method actually is a contraceptive or not, because some people argue that the continuous progestogen in the method should offer some contraception. Because we don't know, we don't make comment on that. And actually, we think the women who are on this method should be postmenopausal women, not perimenopausal women. Because if we start perimenopausal women on continuous combined, they'll start bleed erratically and they would not like it. So we consider that a different thing. If they are on continuous combined, then the assumption is that they are postmenopausal and they don't need a contraception. And I hope that I have answered the questions that we set at the very beginning of the talk, and I'll let you take home your messages, and I will stop sharing. This is the references. The BMS has got a reference on progestogens and endometrial protection. That's very, very helpful, as well as the faculty's guideline. And I'm going to stop sharing now.
Oh, thank you. Thank you so much, Miriam, for the very clear information in your presentation. Actually, it was quite heavy meal, but I can promise all the candidates all the attendees, sorry, that you will find the recording of this webinar on the YouTube channel of the ERC-RCOG, because I believe this presentation you would like to revise more. I have only 2 questions for you because it was really very clear. The first one from Dr. Sami Munir is asking the lady with a quite low AMH, is it enough to not give her contraception, or it is not enough?
We don't regard that as I think we don't do AMH in contraception, so we don't really know. That's for reserve of fertility, ovarian reserve, isn't it? It doesn't tell us about fertility, so we don't look at that. I'm not sure if Haytham wants to answer that or not, but when it comes to contraception, we don't look at that. I think Haytham's going to answer.
Thank you, Miriam. I mean, I suppose really it all goes into the context of cyclical patterns. So out with being on the pill, you would always say you want to link it with what the cycles are doing. I mean, in a fertility context, you see patients who've got FSH in the menopausal range and they're still having cycles. And of course, if they're ovulating, they can still get pregnant. So I think you have to take it in that context. From a biochemical level measurement, yes, it's telling you their reserve is low. There could be perimenopausal. How frequently they're going to ovulate or not in the background, that can really vary. So as a test, it's informative, but you have to take it in the context of a wider picture. And I suppose with FSH, you've got more data on it, and that's why you've kind of got clear criteria of how you look at it. But out with the pill, I would say you look at it in the context of what the cycles are doing, and that's how I would look at it.
Thank you.
Thank you. And the other question is about giving HRT to perimenopausal women on Dienogest for the management of endometriosis. Can we give HRT including estrogen? If the patient is an endometriosis patient and taking Dienogest in order to suppress the endometriosis, if there is any, and complaining of the menopausal symptoms, can we give the HRT?
I think again that's not contraception, but as far as if we are giving them HRT, we're already giving them the progestogen, so we need to top it up with estrogen. And if she's got endometriosis, estrogen and progestogen together, it will be her HRT regimen, won't it? So I don't think there will be a problem whether it's for endometriosis or not. Are we talking about a woman who she's got symptoms of menopause? She's got symptoms of menopause, and you want to give her HRT. She's already on Dienogest. She's already on progestogen. We can give her estrogen on top of the Dienogest.
Yeah, I mean, you've got Clara has got that combination. And from that point of view, you've got data with low-dose estradiol. So I mean, you could say that combination is fine. If we haven't got enough data with Dynagest within HRT as a progestogen on its own, but you've got it's used in Claire, and you could say from that point of view, it's an option. So yeah, it's possible. I mean, if you're looking at it from a point of view of suppression of ovulation to keep the endometriosis pain at bay and give HRT, I would go with SLIND and drospirenone. I think you've got more data on it. You've got combined pills that have it, such as Yasmin and Alawine in the UK. Of course, they've got different names in different countries, but you've got really good data on it being effective with high dose estrogen. So I would generally say, if you're looking at ovulation suppression and progestogen component of HRT and estrogen, I would probably go with drospirenone above Dynagest.
Maybe to explain more the mean of giving estrogen will increase the symptoms of endometriosis again, or just to counteract the effect of Dynagest for the symptom point of view, not for the ovulation suppression.
Yeah, I mean, I suppose if you're avoiding cyclical activity, you're less likely to do that. So you could say, from a point of view of estrogen, I mean, if someone's got menopausal symptoms to start with, their overall estrogen levels are lower, and you're upping them partly and probably not as high as they would have been pre them having the symptoms. So you could say, even with sequential, yes, there's a theoretical risk of aggravating symptoms. But if you're giving continuous combined in any form, you're downregulating the estrogen receptors. So I would say you're less likely to aggravate it. I mean, you could say the same logic of how combined hormonal conception works with endometriosis. You're giving estrogen. Why would they feel better? Because you're giving it continuously. The progesterone is downregulating. The progestogen is downregulating the estrogen receptors. So really, if you're giving continuous combined with ovulation suppression, you're very less likely to do that.
Thank you. Thank you so much. Thank you, Dr. Mariam, again for your presentation. And now what about HRT in high risk for VTE in a young woman with premature menopause? Do we still give HRT, the HRT with the risk of venous thromboembolism?
So if you're giving, I mean, oral estrogen is associated with an increased thrombotic risk. So oral estradiol has an increased risk 2 to 4-fold and front-loaded. So in the first 12 to 18 months or so, not as high as ethinyl estradiol or the combined pill, but higher than baseline. However, transdermal estradiol has a neutral effect on coagulation. Really, you've got good, large observational studies show no increased risk above background baseline risk. In other words, if someone had a VTE, or they've got a high risk of VTE, weight, smoking, family history, etc., you would say their background risk is increased. But if you're giving them HRT containing transdermal estradiol, you're not increasing their risk above background risk. So we do give it in that situation. And in fact, we've just published a series of 101 patients who have all got personal history of thrombosis, either VTE or stroke, who've been on HRT, and we followed them up for more than a year, at least a minimum of a year. And we do it in conjunction with our hematology team. But really, the question is, even if you say, would you give them more thromboprophylaxis? The hematology team would say, if they are at higher risk, that they need long-term thromboprophylaxis, that's regardless of HRT. So they're either on long-term thromboprophylaxis because their background risk is high for another clot. But if we're starting them on HRT with transdermal estrogen, they wouldn't add anything further. So yes, doing it in that combination, keeping the hematology team in the loop, is perfectly safe, and you're not increasing their risk above their background risk. But of course, you should counsel them that their own background risk is increased.
Thank you. Thank you. There another question about the injection of PRP, if it is of any value for the ovulation function in premature ovarian insufficiency.
Yes. What's been published, thank you. What's been published so far doesn't suggest a benefit, and I would say exercise caution, and really I would only offer it within a research study. Fertility, any of you who work in the field, attracts that commercial kind of and lots of things going. Also, it's hope. It's thinking, oh, maybe this is going to work. How many things over the years have come with a big bang that eventually have ended up turning out to be don't work or even harmful? So from that point of view, I would say really only do it within research. How does it work? Well, it's meant to, it's really unknown, meant to affect growth factors, and maybe that kind of stimulates oocyte maturation. But really, we haven't got good data on it. So I would say I wouldn't offer it in clinical practice until we've got more data.
Thank you, Dr. Haytham. Just connecting to Professor Abdelmegid, he has some connection problems now. We can invite our next speaker, Dr. Vikram Sinai, and then we will come back to Professor Sarhan. Dr. Vikram is going to talk about optimizing HRT and HRT in subgroups of patients. A very interesting talk. Please, Dr. Vikram.
Thank you. Thank you so much, ERC-RCOG, for the opportunity to talk today. Some excellent talks already.
I'm sorry, Vikram,
Mariam.
can you just raise your voice a little bit?
Yeah.
The voice is not clear enough.
Okay, is that better now?
Yes, it's better. Thank you.
Good, good. Thank you for the invitation, first of all. We've already had some excellent talks from Mariam and Haytham. So I'm going to concentrate on HRT in specific high risk or subgroups of patients. Initial few slides just to set the scene about menopause, perimenopause. Then we'll look at a few specific conditions, starting from thyroid to migraines to blood clots and cancers. Now, it's a lot to talk about all the conditions in 20 minutes, so it's a challenging task. But I'm going to try and give a gist of everything, each condition, what might be the best HRT to use. And hopefully we can use the question and answer session to go through any details of any specific condition that's needed. I'm going to start sharing my slides now. So hopefully you'll be able to see the slides straight away. Okay, and slideshow. If you could just tell me if you can see them in the slideshow mode now. Yep.
Yes, it's clear now. Thank you.
Thank you. Thank you. So as we know, all of us know the stages towards journey in terms of natural menopause. You have the premenopause before any hormones change. You have the perimenopause. This is when hormones fluctuate. Estrogen levels will be up and down. FSH, LH levels will also change. And we estimate this phase usually will last for about 2 to 5 years for majority of our patients. Could be longer for some, and it'll usually be between 40 to 50. That's traditionally where the perimenopause happens for majority. Menopause is technically defined once there has been amenorrhea for at least 12 months, and for most patients that will happen between 45 to 55, and then anytime from 1 year since the last period until the end of life. As we heard before, 30, 40 years of a woman's life could be post-menopause. And that's why we're all here today, to try and improve the quality of life in that 30, 40 years of phase. Symptoms can vary. Each individual will have a different frequency, severity, and nature of symptoms. There are ethnic variations. So women from Asia, women from Africa may have an earlier menopause. In India, for example, 5 years earlier average age of menopause. So again, important because we need to keep in mind that women may present earlier from other parts of the world than a traditional white Caucasian population. And of course, not to forget the medical or surgical menopause. This is again important. They can have acute menopause following chemotherapy or surgery to ovaries, following cancer treatment or endometriosis treatment. And you often find with abrupt menopause, symptoms can be more severe, persistent for a longer period of time. What are the symptoms? Menopause affects head to toe. Ones that we often don't talk about are the non-classical symptoms, the low mood, the heightened anxiety, the palpitations, again, the vaginal dryness, low libido, painful sex because of embarrassment, because of patients not coming forward. Often the GSM symptoms are missed. So proactively asking for genitourinary symptoms, non-classical symptom, not the typical hot flushes, night sweats, headaches, brain fog, again, that's part of taking the history to make sure we're not missing any symptoms. And symptoms can overlap. So as we look through some of the medical conditions, we know symptoms can overlap quite a bit. Thyroid conditions, for example, rheumatological conditions, psychiatric conditions, a lot of them can have similar symptoms, and the patient may go around the houses to different specialists only at the end to realize that many of the symptoms could simply be menopause transition. What are the current perspectives about use of HRT? We know that HRT remains the most effective medical treatment in terms of the benefits outweighing risk is really key when we prescribe HRT, but it remains the most effective medical treatment. It can be commenced during perimenopause or menopause. So even with the initial menstrual irregularity, although the periods may be happening, one can offer HRT for symptom benefit if there are typical menopausal symptoms or menopause, of course. And then there should be no arbitrary limits. So the old sort of advice about stopping HRT in 2 years or 5 years or 10 years, that's gone out of the window. We do annual assessments, look at the benefits, look at the risks for the patient, any change in their medical history. So that annual once a year review for HRT is really key to decide whether the woman should stay on HRT long term. A number of women now choose to stay on HRT in their 60s, 70s, and 80s. It's an individual decision. There's no good data, lots of studies after the age of 65 with HRT. But again, it's a shared decision between the woman and the patient and you to decide whether you want to keep them on HRT, they want to take HRT long-term or not. So we support women to choose when to start HRT and stop HRT. We heard the talk on POI. Again, the standard recommendation would be to use hormone replacement until the age of 51, which is the average natural age of menopause, because the benefits for quality of life, bones and heart outweighs any potential risk. Choice of HRT, there are more than 35 different preparations commonly used across the world. The ones that we often give first line now as a preferred hormone would be 17-beta-estradiol. That's the preferred estrogen. That's part of the tablets, patches, gels, sprays that we use. What is the progestogen that we prefer if we had a choice? It's the natural progesterone or the micronized progesterone, or its equivalent, the dihydrogesterone, also known as a body-similar progesterone. Those two tend to be better tolerated, have less androgenic effects as compared to the synthetic traditional ones, the norethisterone, the Provera, or the levonorgestrel. And that's because they are less androgenic, the progesterone and the dihydrogesterone. They stimulate the androgen receptor less. They also have less risk of VTE, thromboembolism. They have less impact on the risk of breast cancer. So if we could prefer some progestrogens, it would be the natural progesterone or the dihydrogesterone. But of course, one size doesn't fit all. Some patients may still need norethisterone or Provera or levonorgestrel, especially in the form of the Mirena coil. If they are bleeding a lot, they're having irregular bleeding, you need better bleed control, then often the traditional progestrogens work better, while the natural progesterone, dihydrogesterone, less androgenic, are better tolerated, but may not be the best for bleed control. So it's striking a balance between the effects of progestogen activity, androgen activity, versus bleed control on HRT. Now, what are the advantages of oral HRT? Of course, oral HRT has a higher impact on lipid profile generally. It can provide better LDL, HDL cholesterol ratio. It is superior for women with insulin resistance. There's better compliance. You often find that rather than having a separate estrogen transdermally and the progestogen or progesterone orally, you often find that the oral combined tablets will have a better compliance and less bleeding. Therefore, they can sometimes be more cost effective. There's a better bleed control and less need for investigations like scans or hysteroscopy. But of course, the problem is they are associated because of oral estrogen with the risk of blood clotting, risk of thromboembolism, and so therefore often transdermal preparations will be preferred in those settings. So when do we say oral is an option? When somebody's got no risk factors for thromboembolism, healthy women under the age of 60, no medical problems, patient preference, patient would like to consider oral HRT over transdermal. And of course, aesthetics. Some women may not want to use gel spray or put a patch on them. In all those situations, oral HRT still is a very good option. The world has moved on quite a bit into transdermal estrogen preparations now. So estrogen gel, estrogen spray, estrogen patches are, of course, the most favorite and most popular, highly used preparations now. That's because they don't tend to increase above background the risk of blood clotting. Combination with natural progesterone is metabolically superior as compared to older progestogen. So often these combinations are preferred now. But of course, these are first choice in women who are taking a hepatic enzyme-inducing drug, for example, epilepsy, anticonvulsants. This would be a first choice to go for transdermal rather than oral. Liver disorders, bowel disorders, of course, we're going to choose patches gel spray. Migraines, it appears that the transdermal estradiol delivery gives more sustained levels than oral. And so often with migraines, that's the preferred choice. Lactose sensitivity, of course, limits use of oral HRT. Anybody with high BMI, thromboembolic risk factor, age above 60 and considering HRT, you would always choose transdermal estrogen over oral. Now, women below the age of 60 with no pre-existing medical problems, we said choice is both oral and transdermal. Some women may only have genitourinary symptoms. In those, you can only use low-dose vaginal estrogen. You don't have to use systemic HRT if it's only urogenital symptoms, and you can combine it with systemic HRT if there are systemic symptoms. Now let's look at each of the conditions, and I'm going to go through a little bit fast so that we stick to time. But let's say thyroid condition. We know that thyroid conditions are very common around the menopause, perimenopause. It's very common for women going through menopause to also have underactive thyroid, hypothyroidism. About 20% of women over age of 60 will have underactive thyroid. So a number of our patients will present with hypothyroidism, and they have related symptoms: the fatigue, the hair loss, the dry skin, the temperature fluctuation, the depressive or low mood. They're all typically features which overlap between thyroid and menopause. From limited research, it does appear that symptoms of menopause could be worse if thyroid is not well controlled. So you want to control thyroid with thyroxine as well as have good HRT or other management of menopause. Both conditions should be individually treated so that they help each other. For those with hyperthyroidism, which is less common than hypothyroidism, important factor to remember about bones. Hyperthyroidism can cause bone loss and could be a risk factor for hip fracture. So looking after bones with hypothyroidism during perimenopause, menopause is a key factor. But as I said, it all boils down to managing, treating thyroid condition will help with managing the menopause. What kind of HRT would be your choice? Transdermal HRT, estrogen delivered as patches, spray, gel implants, does not affect the liver protein levels or the levels of the thyroxine binding globulin. And this protein can increase with oral HRT and it will bind the thyroxine, so make less bioactive thyroxine available to the body. And often you have to increase the dose of thyroxine on oral HRT, preferably if you can offer transdermal HRT as it doesn't affect the thyroxine and TBG levels. And that's the preferable form when thyroid problems and menopause happen together. Let's move on to diabetes, another common chronic condition. What are the changes happening with diabetes? We know that there are fluctuations in level of estrogen, progesterone during perimenopause, then eventually menopause. And these are going to alter the cell response to insulin. So there could be more spikes, more falls in blood sugar levels, even with the same treatment of diabetes, which was previously there before perimenopause. There's increased stress from vasomotor symptoms, sleep problems contribute, emotional symptoms can all raise cortisol, and all the stress and cortisol will again have an adverse impact on diabetes control. With age, with perimenopause, there is gradual slowing of metabolism. The fat redistribution happens around the middle of the body. There's weight gain, increasing the insulin resistance. So you can see how many factors are coming together, worsening diabetic control and metabolism around perimenopause. And of course, menopause, remember, will also cause changes to genitourinary tract. So somebody with established diabetes may be more prone to UTIs, urinary tract or vaginal infections. So keeping in mind all those symptoms that are happening, all the changes that are happening, what can we recommend to diabetic patients in perimenopause? Of course, standard things will be eating a healthy, balanced diet, carbohydrates to be regulated, avoiding smoking, reducing alcohol, keeping physically active is really, really key. Calcium in the food, vitamin D supplements, weight-bearing exercise for bone, and then weight management is really the key for type 2 diabetes. But what about HRT? We know HRT has a favorable effect on glucose homeostasis, both in women with or without diabetes. So estrogen has a favorable effect on insulin resistance. HRT appears to reduce the diagnosis of new onset diabetes, beneficial for glycemic control in women with pre-existing diabetes. What kind of HRT would we recommend? It's transdermal again. Transdermal estradiol, oral micronized progesterone would be the most favored components of the HRT. It's not that you cannot use other progestogen, but often oral synthetic progestogens have an anti-diabetes effect. So they can raise the sugars in the blood, which is why you often prefer oral micronized progesterone if you're giving oral progestogen. Other progestogens as part of transdermal delivery, for example, Evorel Conti patches, they're not seen to be associated with fluctuating sugar control. So transdermal estradiol and a synthetic progestogen transdermally combined, or transdermal estradiol with oral micronized progesterone will be your two favorite ways of giving HRT, especially in diabetes context. Individualized recommendations are key though. Depending on all the other complex medical factors associated with diabetes, you will then adjust your recommendations accordingly. Moving on to epilepsy. So epilepsy can be affected by hormones during perimenopause, menopause, so many fluctuations happening with hormones. Sleep deprivation can be a problem. And so epilepsy can become worse. So maintaining, again, a healthy lifestyle routine, regular exercise, balanced diet, avoiding triggers for seizures, that's really key during perimenopause when there are so many fluctuations happening. Hydration, enough sleep, that will be the key part of managing epilepsy during menopause. What about HRT? Yes, of course, HRT can be used. It's not contraindicated with epilepsy, but it should be done with caution. Epilepsy should be monitored when starting or making changes to HRT, especially if you're starting a new HRT regime or first time. Make sure that you're liaising with the neurologist, looking for any triggers. Some medications may need to be monitored with their levels, and that's again individual patient by patient situation. It's recommended to use estrogen through skin. So transdermal estrogen is the best, whether it's a patch, gel, or a spray. A body identical progesterone would be the best, again, because of its typical effects on the brain. And then consider drug interactions and avoid using over-the-counter preparations. So transdermal estrogen and natural progesterone will be your first line, but you can use others based on individual situations. These are some of the resources that the patients can look up and have quite useful information about epilepsy, menopause, and HRT. What about multiple sclerosis? This is another peculiar condition the symptoms can overlap with menopause. And the research currently suggests that menopause can worsen multiple sclerosis symptoms in individuals. HRT could minimize these and improve quality of life. So you can offer HRT in this situation. But depending on how active the patients are, any restricted mobility, then of course you're going to consider lifestyle, non-hormonal, and hormonal management of symptoms. And again, with many patients having difficulties with mobility or other background medical risks, transdermal delivery of estrogen might be the best. These are again some resources. I'll share my slides later so you can point your patients to. Then moving on to next condition, which is unscheduled bleeding on HRT. This is a whole topic on its own, but I thought I would just mention a few things in this particularly typical subgroup of patients who keep bleeding on HRT. We know that unscheduled bleeding has been a problem, and the British Menopause Society recently gave us a nice guideline on managing unscheduled bleeding on HRT. So again, if somebody is on sequential HRT and gets persistent bleeding, what can we do in our HRT to try and get rid of that bleeding? And here are some practical tips for you. If it's prolonged or heavy withdrawal bleed every month, then sometimes increasing dose of progestogen or reducing estrogen dose will help. If it's bleeding early in progestogen phase, there's spotting before the actual bleed comes in, Again, increasing progesterone would be helpful. If it's spotting before withdrawal bleed, sometimes increasing estrogen may help after increasing progesterone. And finally, completely irregular bleeding. Again, you can change the number of days or increase the progesterone dose. For example, if somebody is taking progesterone for 12 days or 14 days, you can increase it to maybe 25 days or 21 days, and that it might give you your monthly bleed. What about continuous combined HRT? Often the troublemaker for bleeding. You can lower the estrogen dose or increase the progesterone dose or change the type of progesterone. And in few patients, you might even switch back to sequential HRT before deciding to go back to continuous combined. There are many other options. The Mirena coil, stopping and restarting. Tibolone could be an option where persistent bleeding is a problem. Sometimes surgery for endometrial ablation and removal of any fibroids followed by HRT might help. So it's too much for 20 minutes, but just to give you some hints and tips on patients with bleeding. What about progesterone intolerance? This is another typical group. A lot of our patients say they start HRT, they like the estrogen, but they hate the progesterone because it causes lots of bloating, mood changes. They don't like the cyclical progesterone or even continuous combined progesterone. Can you do something? Yes, you will usually find one regime that works for that particular patient. So trying a different oral progesterone may help. Provera may work better than natural progesterone, or dydrogesterone may work better than utrogestan. You could use a regime with progesterone in different dose regime. So you could use a slightly different dose. For example, there's a long regime where you have estrogen for 2 to 3 months, followed by 14 days of progesterone to minimize the exposure to progesterone. Yes, there could be small increased risk of endometrial pathology because you're keeping big gaps with estrogen-only HRT. But it's a trade-off between what the patient is expecting, what side effects they are having, and you could monitor their endometrium if they are on a long regime of HRT. Micronized progesterone could be used orally or vaginally, and if it's used vaginally, it should be same dose as oral. Mirena can help many, not that everybody responds to Mirena favorably with progesterone sensitivity, some can still have it, but in some proportion of patients, you might find the Mirena is much better than oral or transdermal progesterone. So a few things you can try, including tibolone would be the last option. Now coming to migraines. So we see so many women having migraines around perimenopause, and it's expected because it's the hormone fluctuation that often triggers the migraines. So migraine is a multifactorial condition, often underdiagnosed, undertreated, and the key is to avoid the triggers. The lifestyle changes will help. Non-hormonal therapies are around, like triptans and beta blockers, but hormones also have their role in management, but the pathophysiology remains complex. The challenge for us right now is who will benefit from HRT and who will not, and it's very difficult to predict that. What's the impact of HRT on migraines? If it's menopausal headaches, often HRT is very good. The headaches disappear. But somebody with long-standing established migraine, it can quite be differential response. So for some, the migraines may improve, but for many, hormones may worsen their migraine. So introduction of HRT may actually worsen migraines rather than improve. So it's a very sort of tightrope to walk between what kind of HRT you decide and monitoring the response. But what's key is whatever HRT you offer, or sometimes you can offer a pill, for example, it's the stabilization of hormones that's key for migraine control. So what you want to do is avoid fluctuation, avoid cyclic HRT as far as possible. So estrogen has a role to play in estrogen-related migraines, and what we prefer is a low-dose, non-oral route of HRT. That's the one that would be preferred with somebody with migraines with or without aura. So continuous combined, low-dose transdermal estrogen, and progesterone or progesterone, again, continuous combined, avoiding cyclic fluctuation, that might work most likely favorably for these patients. The other options include some of the new pills containing estradiol, but again, the thrombotic risk has to be considered with the pills. So continuous HRT regimes will be the first preference. Again, there are very good sources for patients. You got the Migraine Trust and the National Migraine Center. There's lots of useful information where patients can read about menopause and HRT and migraines. Now let's come to the patients who are high risk with blood clots, patients who have cancers. So again, VTE risk in HRT in healthy women. So if you look at cohort of healthy women, no previous medical background of blood clotting and no previous thrombophilia diagnosed, what are the hormones which are the problem? Of course, oral estrogen is associated with increased risk. Some of the synthetic progestogen, Provera, norethistérone, they are associated with an increased risk. But this big study, which was published in BMJ with thousands of patients, what do we see? We see that transdermal HRT does not increase the risk further. So we are quite confident with patches, gel spray in healthy women. What about oral HRT with newer progesterones, like the dydrogesterone? You can see that again, it appears to be neutral in this particular big meta-analysis. So the modern progesterones, like the dydrogesterone or the utrogestan, the natural progesterone, don't seem to be as thrombotic as some of the previous oral Provera or norethistérone. In fact, in this particular study, tibolone appeared to be non-thrombotic, although some of the previous studies have shown increased risk of thrombosis with tibolone. So we did publish about this some time back. What should be the approach to somebody with known thrombosis? And we heard from Hitham as well, that of course it's individualizing the treatment because we know that the VTE risk depends on the route of estrogen and the type of progestogen. And it's the oral HRT which seems to be associated with most increased risk of VTE. So can we offer something else to women with known thrombosis or thrombophilia? Yes, we can. We can offer them transdermal HRT or a Mirena coil with transdermal estrogen. And so far, the clinical experience suggests there is no increased risk about the background or the already increased risk that some of these women have. The HRT won't add any substantial more risk. But it's the personalized risk assessment, and sometimes involving hematology is important for complex cases because if they have persisting risk factors for thrombosis, they may be on anticoagulation long-term, and you can give transdermal HRT side by side alongside their anticoagulation. Watch out for bleeding. You might need to control bleeding effectively. What about menopause following cancer? That's my last bit here. So we know.
Vikram,
Yep.
I'm sorry. If this is the last last subgroup, or yes?
That's
okay.
Right. I'm on my last couple of slides.
Okay.
Yeah. So again, menopause following cancer, we know that there are certain cancers where we can give the HRT and certain cancers where we avoid HRT. And it's usually contraindicated for any estrogen receptive cancers, certain forms of gynecological or non-gynecological cancer. Most cancers, though, we can now offer HRT, and this would be your guideline. So that's my last slide. It's the BGCS BMS guidelines, which are basically giving you information about which cancers it's safe to give HRT, which ones you should avoid, and which ones are in between, where the benefits outweigh risk, you can go ahead and give HRT. And again, this guideline is free to access online, so you can access it online and then decide whether your patient would be suitable for considering HRT. And with that, I'll stop. So that's my last slide, and hopefully any questions I can take in the Q&A. Thank you very much. Thank you.
Thank you so much, Dr. Sinai, for another very rich meal, and thanks for sharing your presentation, your slides with us. And if you don't mind, we can put on our website, of course, because it is full of information. Actually, because of the time, I may only take one question from a colleague who is asking about herself. She's saying, I'm 54 years and have abdominal pain with a history of endometriosis, and the estradiol triggered my cysts. And this has resulted in severe melasma and weight gain. What would you suggest for a replacement of estrogen?
So again, I think you've got, it's not personal medical advice that I can offer on the webinar. But generally, yes, it suggests that you're very sensitive to estrogen, the melasma, the skin changes, as well as any pelvic pain that's triggered by estrogen suggests you're very sensitive. You may have to go for ultra low doses of estrogen alongside progestogen with your history of endometriosis. You could try different routes of having estrogen, although that may not make much of a difference. Tibolone would be something you could consider unless there is risk of thrombosis. It doesn't have the same effect as natural estrogen. You may get away with melasma or any of the estrogen-related side effects. Finally, non-HRT options, of course. You might want to consider the new NK3 receptors for vasomotor symptoms. I don't have time to expand on these more, but those will be roughly the options. I hope that's useful.
Thank you. Thank you so much. Thank you again for your presentation. And because of time, I'm afraid that we may not at the end have enough time for the question and answers. We have plenty of questions in the Q&A section. And I appreciate very much if our speakers can go and answer it directly on the chat, if possible. Otherwise, we will collect it and try to find how we can answer all the questions that we had. Now we come back to Professor Abdelmegid Sarhan to address the non-hormonal options for vasomotor symptoms. And this may answer many questions for those who are not happy with taking the HRT or they have some side effects on the HRT. Dr. Abdelmegid, please. We start where we stopped.
Do you see the screen now?
Yes, we stopped at the slide of the exercise.
Slide of exercise, okay.
Exercise, yes, the first slide of the regular exercise. All this were. After that, one more, please. Yes, the one after.
We start with lifestyle modification.
Yes, we finished this slide. We can start from here.
Okay, who is moving the slides for me?
I am, doctor.
Okay, I can move the slide. You will deal with it?
Yes.
Okay. Regular exercise, consistent physical activity can alleviate many menopausal symptoms, including aerobic activities. The aim is to have at least 150 minutes of moderate intensity aerobic exercise weekly, such as brisk walking, swimming, or cycling, to improve cardiovascular health and manage weight. Strength training incorporate resistant exercise like weightlifting or yoga 2 to 3 times a week to maintain muscle mass and bone density, reducing the risk of osteoporosis. Flexibility and balance. Practices like yoga and Tai Chi enhances flexibility and balance, helping to prevent falls and improve overall mobility. Healthy diet. A balanced diet supports hormonal balance and overall health. Of course, it should include calcium and vitamin D to ensure adequate intake to support bone health. Sources include dairy products, leafy greens, and fortified foods. Phytoestrogen, foods like soy, flax seeds, and legumes containing plant-based estrogens that may help to balance hormones. The important point is to limit triggers, by reducing consumption of caffeine, alcohol, and spicy foods, which can exacerbate hot flashes and sleep disturbance. Stress reduction techniques that manage stress is very crucial during menopause, including mindfulness and meditation, like regular practice can reduce anxiety and improve mood. Deep breathing exercise techniques like diaphragmatic breathing can promote relaxation and reduce stress levels. Engage in enjoyable activities like hobbies and social interactions that can provide emotional support and enhance quality of life. Sleep hygiene. Improving sleep quality can mitigate fatigue and mood swings. The advices given are usually consistent sleep schedule, to go to bed and wake up at the same time daily to regulate internal clock. Have great and restful environment for sleep by keeping your bedroom cool, dark, and quiet. Use breathable bedding and consider cooling device if hot flashes disrupt sleep. Also, you have to limit screen time before bed by avoiding electronic devices in the hour leading up to bedtime to promote melatonin production. Complementary therapies will include acupuncture, mind-body practice, and herbal supplements. Next. The cognitive behavioral therapy is a first-line non-pharmacological intervention, the benefits of which will include reduction in vasomotor symptoms and improved mood and sleep quality. It's recommended mainly for women experiencing psychological symptoms during menopause. Acupuncture. Acupuncture is a practice rooted in traditional Chinese medicine, and it involves inserting certain needles into specific body points. It is claimed to significantly reduce the frequency and severity of hot flashes and to improve overall quality of life for menopausal women. Mind-body practice. Mind-body therapy can be effective in managing menopausal symptoms. It may include hypnotherapy. Clinical hypnosis has been shown to significantly reduce hot flashes and improve sleep quality in menopausal women. Mindfulness and mediation practice promoting relaxation and stress reduction can alleviate symptoms like anxiety and mood swings. Music therapy, listening to calming music. Previous slide, please. Music therapy, listening to calming music has been associated with decreased depression and improved sleep among postmenopausal women. But for completely therapy, you have to be very minded by the fact that efficacy of these therapies vary quietly between different persons, and it should not be the first aid line, and patient interaction should be acknowledged. Healthcare providers should be consulted before starting any complementary therapy. Herbal supplementation. Several herbal supplements are commonly used to alleviate menopausal symptoms. Examples are soy isoflavones. These plant-based compounds mimic estrogen and may help reduce hot flashes and support bone health. Black cohosh, traditional use for menopausal symptoms, though evidence on its efficacy is mixed and it may have potential side effects. Shasberry and evening primrose oil are other examples. One drug, estrogenzo, which had been available in many countries under different names. Yes. It is produced by more than 70 herbs and natural substances. And it helps to relieve the symptoms associated with menopause, such as hot flushes, night sweat, paresthesia, insomnia, etc. The efficacy of estrogen had been supported by many randomized double-blind placebo-controlled studies and different multi-center studies. Okay, just the previous slide, please. Herbal supplements can interact with medications and may not be suitable for everyone. Data from the American College of Obstetricians and Gynecologists concluded that data do not show that herbal dietary supplements like black cohosh are efficacious for the treatment of vasomotor symptoms. And there is a big concern about many cases of liver damage associated with its use. Also, there is a concern about evening primrose oil, whether it is significantly effective in improving postmenopausal symptoms or not. and it's also associated with some bleeding disorders. The other items for postmenopausal care is the vaginal health through non-hormonal options. They are used to provide moisture and lubrication using non-hormonal components. The last item of the non-hormonal therapy for postmenopause is the non-hormonal medications. They include selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, and other medications. For the selective serotonin reuptake inhibitors, the commonest example is paroxetine, which is paroxetine is a selective serotonin reuptake inhibitor that has been studied for its efficacy in alleviating menopausal symptoms, particularly vasomotor symptoms such as hot flashes and night sweats. The dose is 7.5 milligram of paroxetine taken once daily at bedtime. Higher doses up to 25 milligram had been used off-label to treat vasomotor symptoms. There are some safety consideration and side effects of paroxetine, including common side effects like nausea, fatigue, dizziness, and fortunately, these are generally mild to moderate in severity. Drug interaction: paroxetine is a strong inhibitor of cytochrome P450 enzyme, so co-administration can decrease the efficacy of tamoxifen, for example. Suicidal warning: although the 7.5 milligram dose which we use is much lower than doses used in psychiatric prescriptions, all paroxetine containing products carry a boxed warning about the risk of suicidal thoughts and behavior, particularly in young populations. The second group is prevented by venlafaxine, which is a serotonin norepinephrine reuptake inhibitor. It has been studied as a non-hormonal treatment option for managing menopausal vasomotor symptoms, such as hot flashes and night sweats as well. The dose is 37.5 milligram daily for the first weeks, increased to double the dose after 1 week as tolerated by the patient. Dose of 75 milligram per day led to a notable improvement, 51% in patient perceived hot flashes scores compared to placebo, 15%. Common side effects also include nausea, dry mouth, insomnia, and dizziness. Clonidine is an alpha-2 adrenergic agonist used in the dose of 0.1 to 0.2 milligram per day, oral or transdermal. It has modest effective reduction in hot flashes, and it has common side effects of dry mouth, hypotension, and rebound hypertension. Fezolinetant is a new class NK3R antagonist. It has FDA approval the year 2023. It is indicated for moderate to severe vasomotor symptoms, and the mechanism is through blocking neurokinin P signaling in hypothalamus, and it has adverse effects of transaminase elevation and headache. Gabapentinoids like gabapentin in the dose of 300 to 900 milligram nightly for nocturnal symptoms control. Pregabalin 75 to 150 milligram causes more sedation. The mechanism is through inhibition of calcium channels affecting thermoregulation, and this group has side effects in the form of sedation, dizziness, and weight gain. Some non-hormonal approaches used specifically for sleep, including gabapentin, low-dose doxepin, and melatonin agonist. So the main group of drugs used specific serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, targeting vasomotor symptoms and mood. They have side effects related to the gastrointestinal tract and sexual dysfunction. Gabapentin for vasomotor symptoms and sleep. They have side effects in the form of dizziness and sedation. Clonidine for vasomotor symptom, causing hypotension and dry mouth, and osbimefene for genitourinary syndrome of menopause. It increases hot flashes and may be inducing thrombotic risk. So what are the advantages of the non-hormonal therapy? The first one is safety for a specific population for who have contraindications to HRT, such as those with a history of breast cancer, cardiovascular disease, or liver conditions. They have lower risk of serious side effects. They can alleviate mood disturbance and vasomotor symptoms with a safety profile similar to placebo. They have long-term use without hormonal risks. They can be used for extended period without the concern associated with prolonged hormone therapy, such as increased risk of breast cancer and cardiovascular disease. And they are complementary to lifestyle interventions. When incorporating lifestyle changes can change the effectiveness of non-hormonal medication in managing menopausal symptoms. But on the other hand, the disadvantage are variable efficacy. Not all therapies described are equally effective, and the effectiveness of one method can vary among individuals. Slower onset of action. Some non-hormonal treatment may take longer to provide relief compared to HRT. Limited evidence for some therapies. Certain complementary therapies lack robust scientific evidence supporting their efficacy, and the quality and consistency of these products can vary. Potential side effects. While generally safer, non-hormonal treatment are not without side effects. So, in conclusion, non-hormonal treatment can provide variable. Non-hormonal treatment can provide valuable and alternative for many patients who are ineligible for hormone therapy or not preferring hormone approaches. But we have to use shared decision making. Individualized treatment plans are essential. Considered comorbidity and patient goals are very regarded. Side effects should be monitored. Always reassess at follow-up, and we have to continue research to expand available options. Thank you very much.
Thank you so much, Professor Al-Megid, for another very important presentation. It's always very important to have other options other than the hormonal therapy for those who are not for hormonal therapy or are not willing to take in hormonal therapy, and to know the evidence about this. Thank you so much. And here I believe we have plenty of questions, but I believe the time, we are 30 minutes beyond the time, and I know it's a quite long day for many of the speakers and many of the attendees. So we may go to end the webinar at this point, and ask you kindly if we can contact through email to send some of those questions. We may have got some answers and put them again on our website to reply for all those questions that we received already. Again, I'd like to thank you for this very important and informative webinar. I'd like to thank Dr. Haitham Hamouda, Dr. Mariam Nasri, Dr. Vikram Sinai, and Dr. Abdelmegid Serhan for being with us and giving the time and the effort and keeping you with us this late. Thank you very much. It's very much appreciated. And we are looking forward to welcome you in person in Egypt at some point. We would be very happy to have you as our guests. And I'd like to thank Mina Pharmaceuticals for their support for this webinar, as well the marketing house Miss Mariam for all the logistic support through the webinar before and after. Also, I'd like to thank Mrs. Jihan Al-Faki, the ERC CEO, for all the effort she is putting to just put this webinar in this shape. Thank you so much again, and wish you a nice evening, and goodbye. Thank you. Thank you.
Bye-bye, everyone.
Thank you very much.
Bye-bye.
Bye-bye.
Thank you. I'm sorry for this
Goodbye.
technical.
Bye, Wafa. Thank you.
Nice to see you.
Bye-bye. Bye-bye. Thank
Bye.
you. Thank you. Thank you. Thank you so much.